In order to make a big impact, sometimes you have to have a mindset that is revolutionary and not evolutionary. UroLift, or prostatic urethral lift, is one such technology that is revolutionary in the way that we treat BPH patients. My goal today is to bring you guys as much value as I can regarding this procedure and hopefully give us a little bit better understanding of prostatic urethral lift. In terms of disclosures, I'm a consultant and a faculty for NeoTract, the makers of the UroLift System procedure, also known as prostatic urethral lift. I've been recognized as a center of excellence, and currently I'm the most prolific UroLift implanter in Arizona, and I challenge everyone to knock me off my title. Brief outline of what we're going to talk about today: prostatic urethral lift, what the heck is it? I would also like to briefly cover what Dr. Gretzer already went over, the PUL, the BPH statements by the AUA regarding PUL, as well as the cystoscopy and the workup prior to surgical intervention for BPH. And lastly, how do we implement prostatic urethral lift in real life? So that's what I'm going to go over. Prostatic urethral lift, super simple procedure conceptually. It is done through a 20 French sheath transurethral. These little implants are placed along the front anterior of the prostatic urethra, and these implants compress the sides of the prostate, the lateral lobes, to create an open channel. It is done in the office or in the surgery center or in the hospital. It does not cause any sexual dysfunction, no retrograde ejaculation, no erectile dysfunction. The implants are delivered through this little delivery device, and the implants are placed super quickly within 1 second. The needle comes out, the prostatic capsule or tab is deployed, and the suture lingers on the tab, and while the prostate is compressed, the urethral endpiece is deployed, thus resulting in a compressed lateral lobe. You do this from the bladder neck and then extend it distally to the verumontanum to create an open channel. There's nothing out there. There's no minimally invasive surgical treatment out there that creates an immediate visual impact like that at the end of your procedure. The goal is to create an open anterior channel, and to safely do this, you want to deploy these implants horizontally and position it anterolaterally away from the dorsal venous complex and the neurovascular bundle. This is an actual video of a UroLift procedure that I did about
just water running in.
A few weeks ago. Let's see, let me turn the sound off. Maybe I'll leave the sound on.
This is just water.
So this is the anterior urethra. I'm driving the scope in. On the right side, I was demoing a new video system by Redfin, Redfin R3800. It's a portable system with a light source that's attached to the lens itself. Very inexpensive.
Get out of my way. There we go.
So the lateral lobes that you see right there, this is a 46-gram gland. You see a little bit of trabeculations. And when I do this procedure, I try to make sure that I don't have the irrigation fluid running at full blast. I don't want to over-distend the bladder, and you don't want to run out of fluid and having to have the MA change the irrigation. My MA loads the urethral, the delivery device.
The mucosa as I introduce the delivery device.
I try not to stick the bladder mucosa when I put that device in. I find the bladder neck, come back 1.5 centimeters from the bladder neck,
back,
compress the lateral lobe,
lateral compression,
deploy, place the urethral end piece, and then exchange the device again. I'm going to skip forward because all four implants are the same.
Pull up, pull up.
This is the last implant.
Nice big open anterior channel.
And watch the
irrigation.
irrigation is off. And I'll drive the scope in. It's wide open.
Fill of the bladder, and we'll be.
Quickly, I'll go over the AUA guidelines. Position statement number 14, clinicians should consider prostatic urethral lift as an option for patients with lower urinary tract symptoms due to BPH. The discussion about the 80-gram gland, I'm going to talk about an off-label use of PUL. You can't do it on a gland that is greater than 80 grams. The limiting factor is how far can you deploy that needle when the device fires. That needle, the nitinol needle, goes out 33 millimeters. So if the lateral lobe of the prostate is smaller, not as wide as 33 millimeters, uncompressed, you know you can easily compress that lateral lobe and then deploy the needle, and the prostatic capsule or tab would stay. So I have done implants on guys with 100-gram glands, but I take note when I do the transrectal ultrasound about the width of the prostatic urethra and make sure that the hemilobe width is less than 33 millimeters uncompressed. And of course, I talk to the patients before I do the procedure that, yes, the recommendation is 80 grams, but I think you're a good candidate. So that's off-label use. As far as obstructive median lobe, the AUA statement says that patients should not have the prostatic urethral lift if there's a median lobe. Yes, you should not have do the UroLift procedure if there's a big ball valving median lobe like Dr. Gretzer showed. But if you have just a median lobe that is sticking up, that is not protruding into the bladder, you could easily do a UroLift procedure on that patient. It is a more advanced technique, so I do not recommend that you do it right away, right off the bat. You should get some training, become comfortable with the typical UroLift procedure before you tackle the median lobe. Position statement number 15 states that guys who are concerned about sexual function, you should offer prostatic urethral lift to those guys. This is a change from the prior guidelines. In 2003 and 2010, endoscopy was not recommended for the management of bladder outlet obstruction. Now in 2018, clinicians should consider cystoscopy, ultrasound, and take into account any sort of cross-sectional imaging prior to surgical management of that BPH patient. The key takeaways are prostatic urethral lift is included in the guidelines. It is appropriate for eligible patients who want to preserve sexual function, as there is no de novo sexual dysfunction after the prostatic urethral lift. AUA recommends cystoscopy and/or transrectal ultrasound in the evaluation of the BPH patient. And lastly, who doesn't talk to their patients about sexual dysfunction with any surgical procedure that we do for prostates? So that last statement here, that the AUA recommends BPH treatments be counseled regarding sexual function, we all do that already. For those of you who are data wonks, who want clinical studies, who want meta-analyses, I think the prostatic urethral lift is one of the most studied minimally invasive surgical treatments currently available, with 26 peer-reviewed publications, over 120,000 patients treated, and over 480,000 implants placed. You can see that there are multiple meta-analyses, multiple single-arm studies, and according to the BPH man himself, Klaus Werborn, he says that, and I quote, "The prostatic urethral lift clinical publication record is flawless. Every patient treated under a clinical protocol appears in at least one peer-reviewed publication. The outcomes from the numerous studies are consistent, demonstrating rapid symptom relief within 2 weeks and sustained improvement, quality of life, and urinary flow." So let's talk about how this is actually done in real life. I'm with Dr. Gretzer. I don't take PVR alone. I like to get a uroflow and get a context regarding how much is the patient void relative to how much is within the bladder. So for every patient who comes in with lower urinary tract symptoms, or an older guy who's complaining about something related to his urinary tract, I obtain a uroflow and a PVR. If his visit is not applicable to uroflow and PVR, or the PVR is not applicable to his visit, I can simply delete that from the record, and he does not need to be charged for those studies. I think I agree with Dr. Gretzer in that I use the AUA symptom index on everybody. Every man who comes in, even guys who are younger than 45, they come in with urinary symptoms, AUA symptoms index for everybody. It allows me to track his current voiding status subjectively. It's a validated questionnaire, and also allows me to track how did my treatment affect him. This is actually the AUA symptom index from a post-prostatic urethral lift patient, and he wrote thank you with an AUA symptom score of 6 and bother score 0. My medical assistant, before I even walk into the exam room for this new BPH patient, my medical assistant will have given the patient this thing to fill out. In addition, she'll tell the patient, Dr. Lin would like you to look at this video. It's a video player by UroLift called Meet Mike. It goes over BPH, what it is, treatment options. So by the time I walk into the room, the patient already has a very good understanding of what is BPH, and it is typically the cause of this older gentleman's urinary symptoms. Workup for the potential surgical patient. If the patient's interested in undergoing the UroLift system procedure, if he's tired of taking medication, if the medication is not working, if he does not like the potential side effects of alpha blockers like tamsulosin, nasal congestion, retrograde ejaculation, possibly dizziness, and now we have found that there's an association with tamsulosin and dementia. If he's tired of that, or if he's tired of not being able to donate blood because he's taking a 5-alpha reductase inhibitor, if he's worried about post-finasteride syndrome, permanent erectile dysfunction, if he's not happy with gynecomastia with 5 ARIs, I will say, okay, well, let's talk about other treatment options for BPH. Before I take the patient to the operating room, and as recommended by the AUA's BPH guidelines, I will do a cystoscopy on the patient and perform a transrectal ultrasound. I have had the pleasure of going to different practices across the country to help them improve their practices as well as how to manage BPH using the UroLift system. And it's fascinating to me how many practices do not use a video camera when they perform cystoscopies. I use an Olympus digital telescope, and not only do I have a camera and a monitor right in front of me as I'm doing the procedure, so the man is lying in front of me, the head is here, and I'm standing on his right, and I'm doing cystoscopy. I'm looking at a screen right in front of me. I also have a slave screen at the foot of the bed so that the patient can see what I'm seeing. There's nothing more impactful than to show the patient, here's the prostate, here are the obstructing lateral lobes, and look at the changes within the bladder that's going on, that is irreversible, and your symptoms make it worse because of these symptoms and because of these changes within the prostate and the bladder. This is actually a thumbnail image of a YouTube video that I made. So if you look at John C. Lin MD on YouTube, you'll find this video that shows you how to set up multiple monitors in your office if you're interested. If you have an Olympus tower or if you have Storts, it's a very easy setup. We're very fortunate in Arizona in that we can perform the UroLift system procedure under all kinds of anesthesia, including, the way I do it, IV sedation. I have an anesthesiologist come into the office and put the patient to sleep using propofol for just a few minutes, and I can do the procedure sitting at the foot of the bed right there, and similar to the video that I just showed you. In 20 minutes, I can't go over all the nuances of how to do this very, very efficiently. I'm scheduling these patients every 30 minutes, and between these UroLift patients, I have time to go see other patients. So you are making the maximum use of your time, and you are truly giving the patient the best experience possible when you are doing a minimally invasive procedure. If you are interested, my office has an open door policy. I have hosted urologists from different parts of the country, and I will show you everything, how I do things. I even have a local urologist who is physically one street over come over with his medical assistant, and I'm happy to show you how I do things efficiently when it comes to the UroLift system. And if you want to talk about practice management, I'm really big on that too. When it comes to follow-up, When you guys do a TURP, when do you have your patients come back? Anybody? Jim?
After the hospital.
After the TURP procedure,
They come back like 3 to 4 days post-TUR to get their Foley out. Then I usually see them again about 2 weeks after that.
3 to 4 days for the Foley removal, that's what I do too, and then 2 weeks after that for follow-up. Anybody else? Anybody doing minimally invasive surgeries? When do you have the patients come back? 3 weeks? 2 to 3 weeks? Okay, anybody else? How do we come up with that? 2 to 3 weeks, 2 weeks, 4 weeks? How do we come up with that?
I came up with it because the patient responds pretty much. The patients kind of need that support at 2 weeks out because the surgery leaves them with a lot of post-op symptoms that they have to get through. And you have to reassure them that's part of the recovery process.
Dr. Seifer says that in 2 weeks you want to reassure the patients of what's going on and how that is normal, that is typical. Do not be surprised of the frequency, urgency, etc. That's a great point. Anybody else?
Unlike a minimally invasive therapy, I've got pathology to review the patient. So, and my answer to that question about when do you see a patient back, one of my mentors said, when do you want to see your surgeon back after you have surgery? And I said, I'm uncomfortable if I have to wait more than 2 weeks, regardless of whether I've had a urologic procedure or an elbow procedure. I told him when I was a resident about 2 to 3 weeks. He said, sounds like you know when you're going to follow up with your patients too.
Okay, so 2 to 3 weeks based on how you personally would like to when you would like to see your surgeon after a procedure if you had undergone a procedure. Okay, great responses. So much of it is we were told that by our mentors, by our attendings, and after TURP, you want to give the patient some information about what to expect. So much of what we do is dogma. And the only dogma that I trust, or that I believe in, that can't be changed is by the man himself. Everything else, you should question, you should challenge. Instead of 1 week, 2 weeks, 4 weeks, I have my UroLift patients come back in 6 weeks. I agree with Dr. Seifer. Yes, you want to tell the patients that this can happen and you might want to have them come back in 2 weeks. To avoid that conversation after TURP, we give the patients a frequently asked question list, piece of paper, and we verbally go over that with them after TURP when we remove his Foley catheter. That avoids another visit. I will tell you, you may have millions of dollars. There's one thing you cannot buy, and that is time. Everybody values time, including your older patients, especially the younger patients, right? Amazon Prime, we get stuff to us in 2 days. Now that is not fast enough. We all have our cell phones. You got a little latency on your 4G, you're going, what the heck is going on? Time. If I can avoid the patient from coming back to see me, I would do it. And I don't have the TURP patients come back for months. I don't have my UroLift patients come back for 6 weeks. Why? Because during the post-op period, 1 to 2 weeks, frequency, urgency, maybe a little bit of pelvic discomfort, dysuria, gross hematuria, outline on the post-op instructions, so he knows what to expect. And I don't have to handhold the patient. Yes, if they call, we will answer the call, and we answer it with the person all the time. And we take care of these patients without having to frequently see them. So always challenge dogma. The other thing is, and I've mentioned this before in a past meeting, we all perform cystoscopies, most of us perform flexible cystoscopies on a man using viscous lidocaine. Why? Because we were trained to use viscous lidocaine. I will tell you personally, I have not used viscous lidocaine when performing a flexible cystoscopy on a male, including my dad, twice. I have not used viscous lidocaine for years, and we're talking thousands of cystoscopies. So always challenge dogma. Always challenge the way you've always done things. Is there a better way to do it? Can you think about why you're doing it this way? So follow up, 6 weeks for me. And for a lot of you guys who have APPs that you need to keep busy, you may want to keep the patients in your practice. But for me, I want to cure my patients. After the 6-week follow-up, if there's minimal AUA symptom index, if there's no bother score, minimal bother score, I do not have the patients come back to see me anymore. And they're amazed. They're thinking, wait, you don't want to keep seeing me? No, I don't. Go back to your primary care doctor who will take care of you, monitor you for your prostate cancer screening, colonoscopy for colon cancer screening. I have cured you. And what that does for your practice is, I will tell you right now, there are not enough urologists in the country to take care of all the patients who have urologic symptoms. Just for BPH alone, there are 40 million men who have BPH, lower urinary tract symptoms. 12 million men are under treatment. There are not enough urologists. If you all did prostatic urethral lift, there are not enough urologists to take care of all these men. You may be thinking, okay, one solo practice guy doing these procedures, how do my results compare to the LIFT study that was published in 2013? These are I'm sorry about that line. These are my results right here, and this is the LIFT study result. So in 6 weeks, I see a corresponding decrease in AUA symptom index. Great, that's one person's data. What about larger series in real life? Ask and you shall receive. Journal of Endourology, July of 2019, just published. Real-world data regarding prostatic urethral lift. It confirms the clinical efficacy. It's a 2-year retrospective study involving 1,413 men. And it is the largest minimally invasive surgical treatment of its kind. At 2 years, IPSS decreased overall by 37%. And the next question you may be asking is, what about guys in retention? We got guys in retention too. 83% catheter-free at 1 month. And what about age? Older guys versus younger guys. I have performed the UroLift System procedure on guys who are in the 40s. Age does not matter. Younger than 50, older than 50, you still get symptomatic improvement. Then you might be thinking, well, in life, size matters sometimes. When it comes to the prostatic urethral lift, glands that are bigger or smaller than 30 and 80 grams respectively, it doesn't matter. Patients experience symptomatic improvement, and that they do just as well as those with 30 and 80 gram prostates. They also looked at men who have undergone prostate cancer treatment, radiation, and performed the prostatic urethral lift on these men. They all had IPSS symptom score decrease, and there were no more adverse events among the prostate cancer treated patients versus non-treated patients. Among diabetics, you will also see an improvement at all time points. And lastly, it doesn't matter where you do this procedure. You can have this procedure, you can do the procedure in a surgery center, you can do it in a hospital, you can do it in your office. You still get efficacy at various sites of service with in-office procedures done with the least adverse events. So in summary, prostatic urethral lift is a minimally invasive procedure that you can do at multiple sites of service, does not cause any sexual side effects, fast recovery in 1 to 2 weeks. It has been recommended in the position statements by the AUA. It is well studied clinically as well as in real life. And lastly, I ask everyone to challenge dogma in every aspect of your life, whether that is urology practice, whether that is in your personal life. Always think of ways to improve. And I thank you so much for your attention.